It started, the recording is started. Himanshu?
Yes.
Yes, sir.
Okay. Okay, good evening to all. I welcome all of you to this session of SIG Clinical Embryology with IFS Bihar chapter. Today, we are very blessed to have with us Dr. Shweta, who is the General Secretary of the Society. And we are going to focus on role of adjuvants in endometrial preparation for fresh and frozen embryo transfers, then which will be taken up by Dr. Kalpana Singh. She is a renowned clinician. Dr. Dea will be talking on strategies to choose the right procedure, whether IVF or ICSI has to be done. He'll give you the merits and demerits of both. It is followed by a panel discussion on embryo health, which will be moderated by Dr. Pooja Avasthi. Pranay, unfortunately, is not able to join today. And there are some panelists also there, all renowned people. So over to you, Dr. Shweta. Please start the.
Good evening, everyone. At the outset, thank you. It's always, a great moment, and I feel nice whenever I'm invited to open the session on embryology because clinicians and embryologists need to work in sync, and embryology lab is like the heart of towards the success of IVF. And I can see there are really great topics because this dilemma is still amongst there between many clinicians, whether in fact I get many calls where they are very used to doing FET cycles using HRT, and now they have been thinking and hearing about just a natural cycle or a little modified natural cycle, but don't have the confidence to actually go ahead with it or how to do it. So I think it will be very interesting to know that whether adjuvants in the endometrial preparation will be working for embryo transfer from Dr. Kalpana. Dr. Dayanidhi is touching on a very important topic because it's like in the era of antagonist cycle, we say that there is a role of, agonist too. Similarly, in this, at least in Indian scenario, where most of the centers, they feel that, ICSI will bring 100% fertilization and there will never be a TFF with ICSI. So I think, comparing critically analyzing IVF and ICSI and where we can actually, because in my own center, about 30 to 40% cycles are done with conventional IVF. And then it's very interesting and intriguing to hear that what would be the panel which will be unraveling embryo health. So I'm looking forward to it. Thank you, Dr. Kalpana, who's the chapter secretary of Bihar, and Dr. Sarapreet, who's the convener of SIG Embryology, for coming together and for coining such a wonderful program. So over to Dr. Kalpana to start the program, and to Dr. Sarapreet.
Yeah, before that, before we start, we must thank Dr. Pooja Avasthi, who has, convened the whole program along with Dr. Kalpana. So thanks to both of you and Dr. Dayanidhi also. Yeah.
Thank you, sir. So to start the program, I would like to invite Dr. Kalpana ma'am. Dr. Kalpana ma'am is a professor and head of Department of Reproductive Medicine, IGIMS Patna. She is also chapter secretary for Bihar chapter, and her area of interest are fertility enhancing endoscopic surgery. Ma'am, your topic today is a role of adjuvants in endometrial preparation for fresh and frozen embryo transfer. Over to you, ma'am. I'm going to stop sharing. Now you can share your slide and start. Thank you, ma'am.
Thank you, Dr. Pooja, for your very kind words. First of all, I would like to express my thanks to Sarapreet sir and you for providing me this opportunity to speak on this topic. So I'm starting. Is my slides visible?
Yes, ma'am.
Okay. So, role of adjuvants for endometrial preparation in FET cycles. Just a minute. Okay. So what is meant by add-ons or adjuvants? So they are basically any additional medication or procedures which is used beyond the standard hormone therapy to potentially improve the chances of successful implantation. And these includes various medications, various procedures. So like endometrial receptivity assays, low dose aspirin, immunotherapies in the form of intralipids, corticosteroids, GCSF, uh, use of GCSF, assisted hatching, etc. But the effectiveness of these adjuvants or add-ons are still debated because there are various studies. Some studies find that they are useful, but in other studies, they are not found to be useful. So I'll be discussing broadly in these categories: immunotherapy, blood thinners, uterine blood flow enhancers, endometrial manipulators, and a bit about embryological manipulations. So basically, I have taken the most of the references from this ISHRE good practice recommendations on add-ons in reproductive medicine. And this is a recent publication of 2023. So, so far the immunotherapy is concerned, several treatment has been proposed to modulate the immune system. As we know that the implantation process is very important and it is affected by the immunological response of the mother. So these, the treatment includes, there can be in the form of steroids, emulsions like intralipid infusions, then IVIG is a very new entry, then leukocyte immunization therapy, LIT, then use of tacrolimus, anti-tumor necrosis factor agents, GCSF, and hydroxychloroquines. But more recently, some of these treatments like GCSF had been infused in the uterus also. A Cochrane meta-analysis of 14 studies concluded that peri-implantation glucocorticoid provided no clear benefit in terms of live birth or pregnancy rate. The US FDA has assigned the category D rating to prednisolone due to the evidence of adverse drug reactions to the fetus. Though prednisolone is a quite cheap treatment, it is not very costly, but nevertheless, its use has not been approved by neither ISRE or US FDA. Now coming to IVIG. IVIG is an important therapy in diverse autoimmune and inflammatory disorders as well as in primary immunodeficiencies. But there are certain studies which says that it has been found to be beneficial in promoting pregnancy rate. But the recent systematic review, which included 2 small trials evaluating the application of IVIG during ovarian stimulation or at the time of embryo transfer, and it was found that there is no clinical benefit. Now coming to the role of intralipid, in a systematic review published in 2019, it identified only one single trial, and it was a double-blind RCT, which found that giving intralipid to women with elevated natural killer cells levels did not improve the biochemical pregnancy rates. So coming to the ISHRE recommendation, it says that immunomodulating treatments such as intralipid, IVIG, RHLIF, or peripheral blood monocyte treatment or anti-TNF lack biological rationale and evidence of clinical benefit. Additionally, there could be potentially serious side effects. So they are not recommended. Peripheral blood testing for immune parameters like uterine natural killer cell testing and KIR and HLA typing are also not recommended in the context of fertility or recurrent implantation failure as such for practice. So again, on this, the ISHRE recommendation says that peripheral blood tests for immune parameters or uterine natural killer cell testing are not recommended, and KIR and HLA genotyping is also currently not recommended for routine clinical use. Now coming to the use of aspirin. Aspirin is a non-steroidal anti-inflammatory agent, and it acts by inhibiting the cyclooxygenase enzyme in platelets and reduces prostaglandin synthesis. So it causes shift from thromboxane A2 to prostacyclin, which leads to vasodilatation and increase in the peripheral blood flow, and it inhibits platelet aggregations. There are various studies published. So in one RCT is published in fertility, sterility, and it says that there is significant improvement in ovarian responsiveness, uterine and ovarian blood flow, and endometrial growth, implantation, and pregnancy rates improves. Then the other study published in 2012, it found that there is improvement in clinical pregnancy rate, though the live birth rate did not improve much. So further high quality studies are warranted. And in another study which was published in 2014, it was found that there is no benefit over the treatment by using aspirin. So as such, it is not recommended. Now coming to the role of heparin, mechanism of action, we all know that it improves the blood flow at the implantation sites. It also promotes trophoblastic invasion, and it also causes modulation of inflammatory responses and promotes decidualization. Both unfractionated and low molecular weight heparin have been used to promote invasion of trophoblast in the presence of Apler syndrome, but the evidence is weak as such that its routine use to increase the pregnancy rate in wider population undergoing IVF is not recommended as of now. Now coming to the use of vasodilator, so nitroglycerin. So we all know that it is a nitric oxide donor, induces uterine vasodilatation and improves endometrial receptivity. It is given in the dosage of 5 milligram patch, and it is usually used from the day of embryo transfer until the pregnancy test is positive. But in a Cochrane review published in 2018, it was found that there is no improvement in pregnancy rate, cumulative pregnancy rate, or uterine artery indices between the nitroglyceride patch group user or placebo group. So recommendation says that there is not much of evidence. So again, it is not recommended. Now coming to the use of sildenafil citrate, it has been found, this is one of the add-on which has been found to be useful in thin endometrium cases. Ongoing pregnancy rates are good, but overall the cumulative pregnancy rate does not improve. So its routine use is not recommended. The doses which are used in these type of cases, 25 to 50 milligram TID, and vaginal route is preferred. Then L-arginine, we all know, has been used or being used for improving the endometrial blood flow. So it is essential amino acid. It causes vasodilatation, modulates immune system, and it has got anti-inflammatory properties as well. The dose is 6 grams per day, and that there is no solid data in improving live birth rate or clinical pregnancy rate. So again, the current evidence does not support its routine use, and it is not recommended. In a Cochrane review, which was published in 2018, various vasodilators like nifedipine, nimodipine, pentoxifylline, nitric oxide donors such as glyceryl trinitrate, isosorbitrate, mononitrate, and sildenafil. And it says that only sildenafil improved the ongoing pregnancy rates in thin endometrium. Others do not have any benefit, and there is insufficient evidence to recommend these adjuvants. Now coming to a very popular and very important procedure which most of the senior gynecologists usually used to do, that is endometrial scratching. So endometrial scratching is a simplified version of curettage performed with piplet during luteal phase prior to IVF cycles. And the mechanism of action is that it induces endometrial decidualization. Wound healing response is associated with beneficial inflammatory response. Modulation of gene expression involved in implantation and improved synchrony between endometrium and embryo. But there are various studies has been done, various articles are published, and in multicentric open label RCT, it was found that no significant difference in the rates of ongoing pregnancy, clinical pregnancy, multiple pregnancy, or ectopic or miscarriage. Again, in another RCT, which involved 2,537 participants. And here also, there was no significant difference in live birth rate, but clinical pregnancy rate improved after endometrial scratching. In a meta-analysis which was published in 2021, no significant increase in pregnancy rate. So as of now, ISRE does not recommend its routine use. Endometrial scratching, again, this is an article published in 2020. It was here also, the live birth rate were observed 4.6% more live birth was observed in the scratch group compared to control group. Similar biochemical pregnancy losses and miscarriage rates were there. But overall, the pregnancy rate did not improve. So benefit for specific population subgroup has not been equivocally shown, and further studies are needed to recommend that it is beneficial. So as of now, intentional endometrial injury is not recommended. So now coming to screening hysteroscopy, many people do it before doing embryo transfer. So this refers to direct visualization of endometrial cavity or endocervical canal in patients with infertility, despite lack of any apparent pathology, using ultrasound or hysterosonography. Again, the studies has been done, and it shows that there is no benefit with regard to live birth rate. So screening hysteroscopy prior to IVF treatment is not recommended for routine clinical use, but it can be considered in patients with recurrent implantation failures. Coming to endometrial receptivity tests. So RCT was published in 2020 on ERA, and PET on live birth rate after the first embryo transfer. The intention to treat analysis showed no effect on clinical outcomes. The largest RCT on the use of ERA to guide the timing of frozen euploid blastocyst transfer did not improve live birth rate compared to the standard embryo transfer. So recommendation is that due to lack of clear benefit, endometrial receptivity tests are not recommended. Now coming to the role of PRP, it is getting very much popular nowadays. Everybody loves to do PRP. So PRP is platelet-rich plasma. It is based on isolation and concentration of autologous platelets obtained after centrifuging a sample of peripheral blood. And published studies shows low quality evidence. So intrauterine administration of platelet-rich plasma is not recommended. Now coming to the stem cell therapy, again, stem cells have a crucial role in uterine homeostasis and regeneration, and that thin endometrium is consequence of the loss of endometrial stem cells. So no RCTs or comparative studies are available. A large case series included 29 women with previously failed IVF cycles and refractory thin endometrium in whom subendometrial inoculation of autologous endometrial derived mesenchymal cells were performed. The study reported a total of 10 live births and ongoing 7 pregnancies. So it appears to be beneficial, but as we don't have much evidence for this, so as of now, it is not recommended. Further, more studies are needed for its recommendation. Now coming to GCSF use, GCSF is involved in regulating the expression of genes associated with embryo adhesions, cell migration, tissue remodeling, and angiogenesis, which is essential for implantation. Current evidence concerning the intrauterine administration of GCSF is inconclusive because of the studies small sample sizes and mixed cleavage and blast transfer in both fresh and frozen transfer cycles. So intrauterine administration of granulocyte colony stimulating factor is not recommended as of now by ISRE. Now coming to some of the recommendations which has given by a human Fertilization and Embryology Authority in 2022 on assisted hatching, and they say it has been rated gray by them for increasing the chances of pregnancy, as there is insufficient evidence of good quality evidence is lacking. Moderate or high quality evidence is lacking. So they have rated it gray. And on use of embryo glue, again, it is not clear whether this add-on is effective at the in improving the pregnancy rates, because there is conflicting moderate to high quality evidence. Some studies says that it is good, but in other studies it has not been found to be effective. So again, further more studies are needed before we conclude that embryo glue helps in improving the pregnancy rate. So most of the add-ons in vitro fertilization for the endometrium actually doesn't add up. So with these words, I end my talk. Thank you very much for your patient listening.
Can you hear me, Dr. Kalpana?
Yeah.
Very nice lecture, ma'am. I was just wondering, is there anything which is of use amongst the adjuvants?
Most, as of now, there's many studies which says that they are good, they are found to be effective. But when we see the meta-analysis or the Cochrane review, because some studies say it is not good. So when the meta-analysis or Cochrane review or recommendations we see, then most of these add-ons are not recommended as of now.
But
So,
are you using any of them, ma'am? Are you using any?
yeah, we are using GCSF or sildenafil citrate, even embryo glue we are using for
Glue has a role, उसका तो आ रहा है evidence
हाँ,
of.
उसका भी favorable आ रहा है. Only the high level of evidence is not there. So further studies, again, I think after some years, it will come as a part of recommendations.
Yeah, definitely. I think we should definitely use in difficult failed cases. We should try
Yeah,
some.
we are using, and in fact, results are also good. So we are using, and we have taken a study also here to see the role of embryo glue in pregnancies outcome, like what is the pregnancy rate.
Wonderful. And in your government setups, you can conduct so many studies and research, with
Yeah.
all facilities, and juniors are also there.
Yeah. So we have taken this.
Thank you, ma'am. Over to
Thank you.
Dr. Dayanidhi. He's going to talk on IVF versus ICSI, which is the right technique. Dr. Dayanidhi, are you there?
Yes, sir, I'm there. I'm here, sir.
Yeah. Thank you, Dr.
Yes.
Dayanidhi. Over to Dr. Pooja. Dr. Pooja,
Yes, sir.
you can carry on now. I mean, आपको introduce करना है कुछ दया को. I think everybody knows Dr. Daya.
He has himself a slide.
So he is the head of Indra IVF in Bihar, and he is a embryologist par excellence, and very well-known figure in India and abroad also. And he has got I mean, huge number of awards also to his credit, and he has trained more than 100 embryologists in India. So Dr. Dayanidhi, very impressive CV. Over to you for the lecture.
Thank you very much, sir, and good evening, everyone. Good evening, Kalpana ma'am, and everyone, Sweta ma'am. First of all, I would like to thank IFS SIG to give me a chance to present this topic. And topic is very interesting, like how to choose the right procedure for ART treatment, especially in the laboratory, whether we should go for the IVF or ICSI. We all know that the ART refers to a process when the oocyte is fertilized by a sperm outside the body, that is in vitro. And routinely, there are only two techniques that are routinely applied. One would be the conventional IVF and the ICSI. And these all processes, these all IVF process starts, 45 years back in 1978. And we got first baby called Louis Brown, and that was born by natural IVF cycle. And I think IVF, was used for this process, and the success rate of that cycle was around 0.5% during 45 years back. So this is my favorite slide, and I think I have understood very little thing about the embryology, and that that tells that the IVF is nothing but it's one of the most beautiful love story of life, where largest cell of our body, fuses with the spermatozoa, and they form a good quality embryos. And these, embryos are going to give life in the form of a small baby. And as an embryologist, we are the guardian of these gametes for during the culture time, and we must provide all the essential the ingredients or the steps that is very very important for the survival or for getting the successful pregnancy. Now, when we go through the history of IVF, we started in 1978, and even in India, in October 1978, we got first IVF baby by India, Kanupriya Agrawal. In 1991, the ICSI was discovered by Palermo. Then we had GIFT, gamete intrafallopian transfer. We had GIFT, zygote intrafallopian transfer. We had SUJI and the PGD. But routinely there are only two technique that is most widely used in the entire world of in case of ART treatment. There is conventional IVF and ICSI, and these two techniques are most common, in which the conventional IVF allows natural sperm penetration of the egg, and ICSI involves the direct injection, means we are bypassing the natural selection process method, and we are injecting the spermatozoa directly into the cytoplasm of the oocyte or the egg. Now, conventional IVF, the idea was to give mimic the natural environment that happens in vivo, and in this technique, principally the oocyte obtained from a stimulated cycle are placed in a petri dish. Initially, it was done in tube and mixed together with processed sperm obtained from the partner. And it is believed that during insemination, a sperm penetrates the oocyte, depositing the contents of the sperm, that is nucleus, in the cytoplasm, in the cytoplasm of the oocyte. And in these processes, normally we leave gametes are left in place of petri dish for several hours, most probably overnight, maybe 12 to 18 hours, and to allow the sperm to get through the outer layers of oocyte, that is zona pellucida, and the oocyte cumulus complex, and get into the egg. After the insemination, the cubulus and corona cells are removed, and we normally call it denudation process, and the oocytes are examined for the presence of 2PN and 2PB. The presence of 2PN, 2PB normally tells us about the normal fertilization, and accordingly we proceed with the embryo culture. And now, routinely there are various indications of IVF. One would be the tubal infertility, tuboperitoneal factor, endometriosis, unexplained infertility, male factor, where is just moderate male factor, immunological infertility, recurrent IY failure. In case of PGD also, we normally perform. In case of no genetic disorder, we can go ahead with the IVF. Now, when we talk about the advantages, definitely it's less expensive. I think it's the expense of IVF is 8 to 30% less than the ICSI cycle. Then again, it's a tubal factor. We can proceed with the conventional IVF. Endometriosis. This is very very good option for the non-male factor infertility cases. This is very easy and convenient protocol where you don't require much skill. You just need to know the proper dilution of insemination or the sperm, the motile sperm, and then you can go ahead with the IVF process. You don't require a fascinating, the fancy equipment like macro manipulator, the inverted microscope, and so definitely it's very easy and convenient protocol, cost effective. It has got less chances of oocyte damage, and in case of unexplained, definitely it is one of the major or routinely used procedure. Now, when we talk about the drawbacks, definitely there are many people who claims that it has got low success rate. So definitely in the next few slides, I'll be talking about this. It cannot be used for poor quality sperm, especially for the OAT, or in case of some other indications also. The post-mature oocyte or the aged oocyte failed to fertilize by the conventional IVF. Normally, there are chances of total fertilization failure where none of oocyte will get fertilized, and we normally end up with the cycle cancellation. It can also lead to embryo developmental arrest. Chances of polyspermy if the calculation or insemination is not right, or maybe the post-mature oocyte, the chances of polyspermy would be higher. And increased risk of multiple pregnancy. Normally, it just depends on how many embryos you are going to transfer, whether we are transferring day 2 or day 3. But definitely, that the same thing can be in case of ICSI also. Now, when we get total fertilization failure, we have options of doing rescue ICSI. And we all are very familiar with these processes where when we get total fertilization failure, means in the next day, if we don't find any PNPB, we go ahead with the ICSI process again. And we normally, if the embryos are formed, we can do freezing or transfer accordingly. So in case of IVF, we have option of doing rescue ICSI in case of total fertilization failure. Now, ICSI again is a very popular method nowadays. It's an extension of subzonal insertion, and currently it represents more than 50% of IVF cycles. When we talk about IVF cycle, we say overall ART cycles. And in some countries or units, normally we follow 100% ICSI cycle. So people are now shifting from IVF to ICSI cycle completely. Now, what is ICSI? We all know that in this case, we normally, after receiving the oocyte OCC, we keep it for 1 to 2 hours in the IVM. We normally denude it, and we normally catch a single spermatozoa, normal morphological normal spermatozoa, and insert into the ooplasm or the cytoplasm of the oocyte. So we require a very good setup for this. We require an ICSI machine with micro manipulator, definitely ICSI and holding needle, and this is how it looks like when we go inside the cytoplasm. Now, indications again, it is both in case of male factor, in case of non-male factor. In case of male factor, when we talk about the ejaculated sperm, is for oligozoospermia, astheno, teratio. Anti-sperm antibodies, it is one of the major indication. I think it's one of the very good indications in case of anti-sperm antibodies. Ejaculatory disorders, electroejaculation, where we get very less spermatozoa, retrograde ejaculation, globozoospermia definitely is a very important indication. Cryptozoospermia. In case of testicular, definitely is one of the main indication. Necrozoospermia, all indications for epididymal sperm, non-obstructive azoospermia, hypospermatogenesis, where we get very less spermatozoa. In case of epididymal, also obstructive azoospermia, CBAVD, Young syndrome, failed vasoepididymal dermostomy, failed vasovasectomy. In case of non-male factor, definitely nowadays we use for the clear failed fertilization with IVF, oocyte dysmorphism, a low number of oocytes when we have only 1 or less than 5 oocytes, low oocyte maturity, where you denude the oocyte, you keep for IVM for a slightly longer time and perform ICSI. In case of IVM, where we get the GB or M1, and then you do the IVM and perform. In case of PGD, PGS, FIS or PCR, HIV and HCV discordant couples, restrictive legislation. So these are the major indications given by Palermo in 2018. And so if you see, there are varieties. There are a very good number of indications where ICSI can be a very good option for fertilization. Now, this is the slide given by S-Ray showing the distribution of IVF ICSI from 1997 to 2010. So when we see in 1997, we were doing almost 65% cases of IVF and 35% cases of ICSI. But when we talk about 2010, it was just reversed. 65 to 70% of cases is ICSI, and now only 35% of IVF. Now, when we talk about 2025, I can tell you 90% of cases are ICSI, and only 10% centers are actually using the IVF. So there is shift from IVF to ICSI. Now what are the risks associated with ICSI? So it requires very skilled based cycle failure. Definitely, if there is no fertilization by ICSI, you don't have any option. Embryo arrest can happen if it is not done properly. And there are some literature which say that the birth defect are associated with ICSI cycle, ICSI technology. Anyway, we'll just go through this in the next few slides. Now, the key difference IVF versus ICSI. The fertilization method again is sperm naturally penetrates the egg, whereas in ICSI, it's sperm is directly injected into egg. Best suited candidate or indication as per literature, IVF for unexplained infertility and normal sperm count, and ICSI severe male factor infertility and failed IVF cases. Fertilization rate depends on sperm quality in case of IVF. And in ICSI, it is claimed that the fertilization rate is higher even with poor sperm quality. Risk of fertilization failure is higher in IVF compared to ICSI. Cost and time, IVF is less expensive, simpler. ICSI is more expensive, requires more expertise. And risk factor, as I said in the beginning, is the chances of total fertilization failure. Now, this is the data meta-analysis of IVF versus ICSI, and these we have just clubbed the paper published in between 2000 to 2023, and so again we have divided into two periods, 2000 to 2010 and 2010 to 2023. So in the 2000 to 2010 showed ICSI had higher fertilization rate versus IVF in male factor cases, and they concluded that the live birth rate comparable. Concerns over genetic risk in ICSI was raised by many scientists. In the last 13-14 years, we did not get significant difference in live birth rate for unexplained infertility, and we have seen over use of ICSI. Definitely it improved the overall, maybe the embryo freezing, reduced ICSI, so that all improved. But yeah, we have not got very convincing or very the report where they say that the ICSI gives higher fertilization rate, higher improved pregnancy rate. So we have not received any information regarding this, or there is no paper. Now I have also gone through the success rate based on meta-analysis between in the last 25 years. So they say that ICSI has a higher fertilization rate, and that we all know the scientific reason, since we are bypassing the entire barrier. So definitely we can expect a better fertilization rate, but this does not always translate to better live birth rate. So LBR is same. For non-male factor infertility, ICSI and IVF yield similar pregnancy rate. So if it is non-male factor, where the male is normal and there's a problem in the female, so IVF ICSI yields similar pregnancy rate. The choice should depend on the couple's specific infertility condition, and proper evaluation is must before deciding about the procedure. Now this is again the paper published in in Journal of Clinical Medicine in 2022, the opportunity and limits. So they have compared between the the fertilization rate, pregnancy rate, and the clinical pregnancy rate. So they have not found a significant difference between the IVF and ICSI. Now this is very interesting that here they have compared the aneuploidy rate and euploidy rate, and even in this meta-analysis they have not found any significant difference in the aneuploidy or the euploidy status of the embryos. And in last paper was published in 2020, where they said that even in the IVF the euploidy rate was 50%, as whereas in ICSI it was only 45%, but both were not significant. Whereas in 2017 it showed that the euploidy rate of ICSI cycle was 70%, whereas in IVF it was 65%. So definitely is not very different. Is comparable. And finally, they see that in case of advanced maternal age, in case of decreased ovarian reserve, endometriosis, autoimmunity, PGT, and single. So I have just clubbed, or I have just wrote their finding in a very simpler manner. They say that in advanced maternal age, no advantage of ICSI over IVF in fertilization, embryo development, pregnancy, or live birth rate. So in case of advanced maternal age, it's not that ICSI can be very useful. In case of decreased ovarian reserve, fertilization is compared. Implantation, pregnancy, and live birth rate are similar. In case of endometriosis, ICSI has higher fertilization rate, but definitely they did not find any significant improvement in pregnancy or birth rate. In case of autoimmunity, definitely ICSI helps in anti-sperm antibody cases, but not for thyroid autoimmunity. So in case of ASA, ICSI can be the first choice for fertilization. In case of PGT cycles, comparable embryo diagnosis and transfer rates between IVF and ICSI. And when we get single oocyte, definitely again there is no difference in fertilization. But as per my experience, I normally prefer ICSI in case of single or when the oocyte number is very less. This is the paper published in 2 years back. Should ICSI be implemented on patient with poor quality embryos in the previous IVF cycles? So definitely in this paper, they concluded that the ICSI significantly improved the high quality embryo rate and clinical pregnancy of the patient with poor quality embryos in the previous IVF cycle. So definitely, if we get a patient of 1 or 2 IVF cycles, we can go ahead with ICSI over IVF. Now again, this is the paper where they have compared the fertilization rate and pregnancy rate in case of endometriosis, and they conclude that ICSI appears to be a better treatment option than conventional IVF in case of endometriosis associated infertility, since it offers the advantage of high fertilization rate. So definitely we get more number of embryos, and we can expect a similar pregnancy rate, but fertilization rate is higher in case of endometriosis. So now it's like it's a very big question when to choose IVF versus ICSI. As per literature, choose IVF if male partner has normal sperm parameters and there is no history of failed fertilization in previous IVF cycle. You can choose ICSI if there is severe male infertility, that is low count, motility, or abnormal morphology. Previous IVF cycle resulted in failed fertilization, or if PGT is required. In that cases, you can prefer ICSI. Now, what are the risk and consideration to decide about the procedure? So IVF, as I discussed and I told many times, it has got higher risk of total fertilization failure in male factor cases. In that condition, rescue ICSI can be an option. The ICSI, there is a possible increased risk of genetic disorder, which is actually not proven till now. Definitely, we have crossed 25 years, approx 37 years of ICSI era. But till now, we have not got very convincing, report where they have got increased risk of genetic disorder. So it's again question mark. So we'll have to check for the next 10-15 years maybe, where maybe some epigenetic changes might be observed in the offspring. But both method, IVF or ICSI, require careful patient selection to optimize outcome. And we all know that ICSI cycle is average cost 8.5 to 30% more than an IVF cycle. So because of high cost, we can actually check whether to go for IVF or ICSI. Now I have done a short analysis of ICSI, and this is it shows that the strength of the ICSI would be increased fertilization rate and decreased fertilization failure in patients with unexplained infertility. Again, its strength is decreases fertilization failure in patients with borderline or subfertile semen, minimizes the risk for cycle cancellation in couples with prior failed IVF, could improve embryo quality, could increase pregnancy rate in patients with sperm zona pellucida fertilization disturbance when there is abnormal interaction between sperm and oocyte. It also avoid possible contamination with DNA from spermatozoa in case where PGT is performed for monogenic condition. However, the weaknesses or negative points of ICSI would be no standardized guideline to define severe male factor infertility. So till now, I don't know. I have not got a very good guideline. Invasiveness and complexity of the technology, because it requires highly skilled embryologist. Operator experience and technical factors are critical, because the skill is very important. And but unfortunately, I did not find a single paper where the ICSI or the IVF fertilization rate was compared based on experience of the embryologist. So it's very it would be a good point when we can compare with the less than 5 years of experience of embryologists or more than 5 years, and then fertilization rate and the embryo quality. Again, it's a complication. Imprinting DNA methylation sex ratio. There is no benefit of ICSI on women-related factors of poor prognosis. No effect on reproductive outcome. No evidence of cost benefit. Lack of well-designed randomized study. So these are the weaknesses of ICSI. Opportunity, external factors with possible positive impact could be selection of the oocyte. We can select the oocyte based on for the ICSI process. Technical improvement, we can increase the IMSI, PIXI, artificial oocyte activation, genome editing, and threats can be indiscriminate application of the technology, ICSI overuse, improvement in IVF, and possible long-term effect. So just to conclude, I would like to say that both IVF and ICSI are very essential ART technique. IVF is suitable for normal sperm cases and is less invasive, whereas ICSI is necessary for severe male infertility or failed previous IVF cycles. Recent studies suggest no added benefit of ICSI in non-male factors, and we know that the cycle cost of ICSI would be higher than the IVF cycle. So choose wisely. And also I'm big concerned that nowadays most of our young embryologists may not be knowing IVF only. They may not be knowing the calculation part only, insemination droplet only. That is my major concern. I don't know whether they know or not, but yes, as an embryologist, we should know both the techniques scientifically so that we can use it. Suppose your ICSI machine is not working properly, if there's any problem in the ICSI machine, at least you will have option of doing IVF in case you know the technology. So thank you very much, everyone. Thank you.
Thank you, Dr. Dayanidhi, for the wonderful presentation. You almost covered everything. So I have few doubts. I think some of us may have few doubts. So what do you understand by severe male infertility? How you define severity? There's a low count.
Less than 1 million, less than 5 million. Normally I consider less than 5 million. as a severe.
So less than 5 million, and that is why I think the aneuploidy rate is higher, because already the sample is in severe male infertility. It is already compromised sample. Maybe genetically also, morphologically also. That
Yes.
there must be some reason behind low sperm count. And
Yes. So you can expect, the ageospermic factor also, like, the age deletion of the, Y chromosome macro deletion, you can expect so many other things also, right? In case of severe, uh, the male factor.
Actually, I too want to ask a
yeah,
question.
please, ma'am.
Yeah, in cases of endometriosis, what is your practice at your Indra? So, do you people ever do IVF or always ICSI?
Ma'am, to be very frank, we do 100% ICSI.
In our institute, we do IVF and ICSI both.
Yes,
We are
ma'am.
doing both.
Many people do, ma'am, half IVF, half ICSI, but that again is a time consuming. And I believe that, we can go ahead with either IVF or ICSI, because when we mix these
So
two, the
not
cost will be
half,
higher.
not half, but if we have got good number of oocytes and there is non-male factor infertility, then we do IVF as well. But in cases of endometriosis, I wanted to know, because in severe endometriosis, is it recommended that we should do ICSI only?
Yes.
And
But maybe because of interaction, ma'am, because in case of endometriosis, there might be some problem with the sperm oocyte interaction. And in IVF, we know that the receptor, there might be some disturbance in the receptor of the zona also. So that's why maybe they are recommending ICSI in case of severe or endometriosis cases.
Ma'am, this is actually a learning for me, but in endometriosis, why will you like to do ICSI and not IVF? I mean,
No, I read in an article that in stage 1, 2, IVF and ICSI gives good result, but in cases of again very severe endometriosis like stage 4 or deep infiltrating endometriosis, the oocyte quality these things get affected.
the quality of oocyte is affected, yeah, in endometriosis.
And in that, their ICSI is recommended. So I just wanted to know the opinion, like what is your experience? What do you say, or what you people do? Because we do both IVF and ICSI both, so we can take IVF as well. But what is the standard practice, or what is your experience? I just wanted to know.
Yeah, in most of the cases, we also generally, if it's a good sample, we go for IVF only. And yeah, we talk to the patient, explain them many times. They'll ask us for ICSI. We'll do a split fertilization. And in a severe male and indications cases, we will go for ICSI. Because a lot of, I think IVF is a good technique. I mean, we have been getting good fertilization.
Yes.
So we've never, and rate of total fertilization failure is very low. In good hands, it is extremely low. And we are doing only short incubation. We change the media after 3 to 4 hours of incubation.
Okay, that is a good point.
Hmm.
So after 4 hours, you change the
Yeah, from fertilization media, we move to the cleavage media, or if you're using single step, then change to a new dish, new media.
Sarapri sir, when do you do PN assessment in that case?
18
For
hours,
short
16 to 18
incubation?
hours.
So
Next
that
day.
normally you keep on the same time, but
Yeah,
only you
yeah.
change just the, maybe just to avoid polyspermy fertilizer. What's your, logic behind this?
See, the logic is that fertilization happens within an hour of insemination. Fertilization will be taking place. So as a buffer, we are dragging it to 3-4 hours just to be, mentally secure. So when the fertilization has happened, why do you want to keep the sperm and egg together? Sperm is anyway going to die. It is going to release ROS. It is going to spoil the culture conditions. So quickly change the media. I mean, don't denude. If you want, you denude also. I mean, there's nothing wrong in denuding, but it will take time. You quickly change to the other dish. I mean, only the cumulus would have gone away. Only the oocyte is stuck to the plate. Just keep picking the oocyte. Suppose you have kept 6 oocytes in one dish. Just pick the 6 up and next. Quickly, don't waste time. That is most important. Don't waste time. Quickly change the dish.
And I guess during that changing the dish, we somehow denuded a little bit of cumulus
Yeah,
also.
yeah, yeah, because you pick with 170, so थोड़ा सा denude तो हो ही जाता है.
Yes, yes.
Yeah, but you don't do denude it, but you can denude also because fertilization has taken place. So
But many people say 6 hours is the, मतलब many
no,
people
no,
practice as
no.
a
I
six
have
hours.
changed media after 1 hour also, and I've got wonderful fertilization. But
Yeah.
it is a little tricky. You might end up getting, low fertilization. So 3 hours is very safe bet.
Yeah.
3 hours. But if you have time, you can drag it to 4 hours. Yeah.
There was a point in their slide that advanced maternal age. So Dayanidhi is suggesting not to go for ICSI IVF. So
No. I did not suggest
That
that.
is
Very
because of,
clearly.
Dayanidhi, it's a
yeah,
general query. It's a general
Yeah.
why?
query.
I
Majority
tell
of
you.
time with the maternal age is advanced. Every clinician wants to do ICSI to make sure that fertilization has happened. Or
No, this is very tricky actually. He is actually right in it's a point of view. But if you've got just one or two eggs, then ICSI in bad hands. Number one, the eggs can be fragile. So doing more intervention will cause them to degrade if you are putting in a needle, invasive technique. Secondly, there are just if there are just one or two eggs, you can't take any risk. And if the sample is good, the chances of getting fertilization are as good as getting them in ICSI. So, and the damage is not there in IVF. So, especially, I can take names, but good labs from South and all, they are doing in low set count, they are doing IVF as a routine, even in advanced age.
I also prefer many times if
Yeah.
obviously if the male partner is all good,
Hmm.
then IVF is the best way to perform.
एक या दो ही अंडे हैं, so chances of getting
Why
damage,
not?
losing everything are
But
there.
I
But
wanted to
sir,
know what
I
Daya
just
does. What
no.
Daya does.
No, even
I wrote in my slide that there is no difference. But when it is only one or two site, I normally prefer to go and do ICSI in the lab because you need, as Sarapri sir rightly said, the expertise and the skill is very
yeah, if
important
you're
because chances
skilled.
of damaging the oocyte would be very high. So definitely you can go through you know your team better, right? So you can decide on agar if there is a normal sperm semen parameter, definitely you can go ahead with the IVF, and there is no difference between fertilization rate, pregnancy, and other thing, right? So
And I would like to share an experience. I used to visit a lab close to Delhi, and they somehow, we tried doing ICSI because ICSI is the gold standard, as everybody says. And we used to get a lot of degeneration in their lab because they used to pump a lot of hormones and probably, more of donor cycles, a lot of eggs, a lot of degeneration. So the moment we switched everything to IVF, the number of embryos, the number of embryos for freezing, transfer, they increased so much that till date, even after leaving the lab for almost 5, 6 years before COVID, I stopped going there. When I talk to them now and they say that, sir, IVF ही कर रहे हैं हम तो, because they have been getting result in IVF compared to ICSI. So it depends on oocyte quality also so much.
sir, I have done, I think 20-30 processes of the procedure where we got only one oocyte. We performed ICSI and we got pregnancy. So it's about the experience, and so
Yeah, yeah, it is all about experience. Yeah,
it's
if
all
you
about the
think,
good
हाँ,
experience and the technology that you use.
egg
And
अच्छे हैं तो हो जाएगा, ICSI भी हो
yes,
जाएगा, ऐसा नहीं है, but
yes.
risk
We
वाली
all
बात.
do the customized and tailor-made approach for that particular patient. But why I raise this question, because we have joined with a lot of clinician and they are kind of always afraid of कि ICSI कर दो. Don't do IVF कि शायद fertilization आए या नहीं आए.
Yeah,
So
but then you have to give them confidence through split fertilization and then move to, पहले
So
तो IVF ही होता था.
yes, yes.
as I
पहले
said, it
इतनी
depends
मशीन
on
होती भी नहीं
the
थी एक जमाने में तो.
as Sarapri said, na, and even you accepted that it depends on the confidence that the clinician will have in their team. And if they
Yes.
are confident enough, like we all can decide. So definitely, it's about the skill and it's about the technique.
Technique. Okay, so moving forward to the panel discussion. So today's topic for panel is embryo health revealed, profiling for the success. And moderators is me, Dr. Pooja, and my dear friend Pranay is not able to join, so apologies from his side. And in panel, Dr. Sarapri sir can also help me in moderating. So we have Dr. Sarapri sir, Dr. Pooja Singh, Dr. Dayanidhi Sharma, Dr. Indra Prasad, Dr. Sharda. embryologist Sangeeta Kumari, and embryologist Dimple is not able to join us today. So moving ahead. So the short CV of Pranay, since he is not here. So I'm a senior clinical embryologist. I work at Sitaram Bhartiya. And Dr. Sarappreet, a very well-known figure, is a head on clinical embryology and andrology at Artemis Hospital. He also run in the Fertilis Academy, and he has achiever and lot many awards to his name, and is a teacher of teachers. So next to Dr. Dayanidhi, we all know him. He is a very significant impact. And one thing I liked about the first line, first embryologist India pursues master in clinical embryology and PhD in clinical embryology 2014. So yes, kudos to that. But we have lot many in the market. So yes, you are heading now. Next, we have Dr. Indra Prasad with us. She is additional professor, Department of Obstetrics and Gynecology, AIMS Patna. She's very dear friend of mine, and I find her very, very interactive, intelligent, and very kind-hearted. Welcome, Dr. Indra. Then we
Thank you,
have
Pooja.
Hi. Then we have Dr. Pooja Singh with us. She's MBBS MS Fellowship in Infertility, and she is a center head at Indra IVF. So welcome, Dr. Pooja. Along with, we have embryologist Sangeeta Kumari. She is BSc MSc. She has 6 publications, 6 years of experience, and she is working at Indira Gandhi Institute of Medical Sciences, Patna, Bihar. Sangeeta, most welcome. Dimple is not joining us today, so I will start the moderation. Hope that it will be interactive. So welcome all the panelists. Along with the panel, I also would like to invite all our audience to participate if they have anything to say or an experience they can share. So let's start with the basic. What is the role of lab environment in maintaining the embryo health during the IVF process? Anyone can start.
Can I start? I'm Dr. Shraddha Chakriya from Patna.
Hi, Dr. Shraddha Chakya. I'm really sorry. I could not get your CV, so I cannot integrate you in that. But most welcome, madam.
Okay. So, an IVF lab for an IVF center is very important. It is supposed to be the womb of a mother. So, the health of an embryology lab is very. The entire team is responsible. It is not just the embryologist, the doctor, that is the chief IVF clinician, the other staffs, the nurses, the counselor. They should be aware. They should be aware what is to be maintained in an IVF lab. That is the right humidity, the right temperature, the monitor which maintains the CO2, which looks after the VOC level of the lab, how the lab is maintained, the cleaning, the mopping, the incubators, whether they are regularly monitored, the gases, the pressure is properly maintained, everything that has to be looked upon. And if the equipments are doing well, then only the team is good, then only we'll get the good embryos, and then only the IVF will be beneficial to the patient.
Rightly said, ma'am. Anybody else? Yes, Sangeeta, you are the embryologist.
Yes, ma'am.
What take on that?
A very good evening, ma'am. Of course, ma'am. The embryology lab provide well controlled. It provide controlled environment in the lab, like stable temperature, which is like same mimic the in vivo condition, gas concentration and pH balance, sterility, air quality, culture condition, and also provide the minimized light exposure. Also monitoring matlab, in recent technology like time lapse imaging also provide the safe and zero touch embryo handling process. This.
I want to add one more thing, that HVAC unit which maintains, that should be properly regulated. We should know how many air exchanges are there, whether it is undergoing proper AMC, regular monitoring, regular cleaning, those all things has to be done.
Right.
I would like to add that good communication between the embryologist and the clinician in the who and ticking all the checklist is very important for the lab before coming in and going out. That to see the air quality, pH, VOC, all these things should be humidity. All these meters are there. Even if not there, there are other ways how to check. But that has to be. It's a duty of both the embryologist to does only, but even the clinician should be in a constant communication, and that is very very important because 50% is the clinician's role and 50% is the laboratory's role with embryologists. So it is very important.
So very well point taken up by Dr. Indra Prasad. So basically, we all know that Dr. Shraddha, Dr. Sangeeta Kumari, they have mentioned a lot of points. What should be the lab environment? So we should also be knowing that what is the things, what are all these things are monitored properly or not. So we should be having, like Dr. Indra said, both are the equally responsible. So now in the market, there is so many lab health gadgets, IoT devices, they are there. You can just place them. You can have the update periodically that yes, everything, pH, humidity, and particle count, everything is going in a smooth way. So that
one thing I want to add, that definitely there are so many gadgets which are looking after it, but nobody knows how much it is validated. So from
that is the another point. Whenever we are installing any gadget, so obviously calibration of gadget is equally important as the equipment calibration, right?
So calibration more than calibration is about the AMC. So whenever we buy any gadget, we must take AMC of that gadget so that it can be properly calibrated throughout the year. So that's a basic thing which we need to, on any IVF center should go for AMC for each and every gadget.
Right. Dr. Sarapreet, you're there?
Yeah, Dr. Pooja, yeah. I think the points have been covered. And I would also like to say that alarm systems are recommended for, and alarm systems and data loggers, they are also a must. Round the clock monitoring, at least, if you're doing it manually, you should check the instruments twice in a day, maintain a logbook, make the entries, and cross check also, whenever you're there in the lab. If you're not there in the lab, the technician or the duty attendant has to do it. They have to be trained to do it. So those things also help in, fighting with the exigencies and reporting early. Even the cryo rooms have to be checked at least one to two times in a day. And all other gadgets, even the room temperature, everything has to be checked. And a logbook. Better is to go for alarm systems which are giving you a 24/7 data logging, and maybe you can, have all the data in your mobile phone also.
Right. That's, I think, one of the beautiful things which come up recently, that monitoring and checking of alarm system. That moving to the next question. So in addition to a controlled lab environment, what are some key culture conditions that support healthy embryo development?
The most important, I would say, carbon dioxide and oxygen levels, because that is very important to maintain the pH, which should be between, it ranges between 7.2 to 7.4, though the incubator starts beeping whenever there is a issue with the CO2 concentrations and the pH. So that is important. And of course, the air quality, the media, and the dish, and no contamination should be there in the dish also. So these are the key things that are important.
So it should be monitored properly, like Dr. Indra Prasad has said. The liquid nitrogen cylinders, the CO2 cylinders, the media, the refrigerator, it should be monitored. There should be the beep system for that. And we should also, prior to like using span in which the media has to be used, especially the one-step media. Those things have to be looked upon.
Anything from the embryology side, Sangeeta?
And this
Yes, ma'am. Using appropriate dishes are also play a very significant role to maintain which kind of you are
secret.
using culture dish. The different centers have using different type of culture dish, like a center dish or maintaining the drop size also for culturing the embryos.
So what you do
And
in practice? Do you prepare the dishes prior to cases, or you allocate the media and prepare the dish just before that case started? How you do it?
ma'am, we incubate the media in test tubes previous day, and on during case before 2 hours we make the culture dishes and culture them.
Okay, Dr. Daya, I just want your opinion on that. What you suggest? We should allocate the media, or we should prepare the dishes?
Normally, we use at Patna Center or in the entire Indra IVF group, we used to allocate media and keep it in the evening. And next day we used to prepare the dish. But nowadays we change the protocol. So now we do allocate the media for sure, and we prepare the dish and then keep in the incubator. So that's what now we have changed it. But allocating media is very, very important, because the same media you are taking it out again and again, so definitely it will affect your the pH and the osmolarity. And in my experience, there are only three the factors. If we can control these three factors like pH, osmolarity, and temperature, then we can get very good embryos in the laboratory. So the entire the skill or entire the process we do in the laboratory is just to control these three factors. And these three are very, very key factors, which is very, very important for the embryo development.
Right. So just the extension of this question, how much time we should be taking during the procedure, like when we are doing the PN check, if we don't have the time lapse? What is the minimum exposure time or maximum exposure time you can just you use, or you guide us to use? Or for the handling list, we have done the perform the IVF, we have to denude and shift the embryos to the next dish. So what should be the minimum or maximum time we should be taking for this period, so that embryo should not be overexposed to the ambient air quality?
Yeah, minimum to as fast as possible, or maximum I think we can safely do it in within 2 minutes. And those 2 minutes are for if you're checking 2PN stage or any other stage of embryo, it's an covered dish with the lid on, and you examine on the XC machine or the stereo microscope. It should be covered with oil, and the lid should also be not be removed. You can easily view. People remove the lid. That also causes the loss of temperature and pH very, very fast. So keep the lid on and check it quickly and put it back. So 2 minutes I think is a safe limit. और 2 मिनट में हो जाता है मतलब comfortably. I mean it's not a it's
Yes,
not
yes,
a less
two,
time.
2 minutes
It's a
is a
good
huge
time.
time.
It's a
When
good
we
time.
do the vitrification, even 60 seconds seems like so
Hmm.
much of this thing. So do you believe that, so come to the lab culture system, and now just talk about little bit of the equipment. So do you believe that lab equipment have their shelf life, or?
I think it's about maintenance and the use. अगर बहुत सारे लोग use करेंगे तो they're not going to survive long. And if you're not giving AMCs, you're not calibrating them, you're not maintaining them regularly, so they will trouble you, quickly. If you don't have power surge meters, they are bound to trouble you more often than required, than normal.
So
Okay.
let's say it's a box incubator. So what is the maximum year we can use it with the proper, obviously, calibration and making all the things in place?
We are using our box incubator since 15 years and they are doing well. एक का खराब हो गया था, the CO2 sensor which we got changed. The other one is functioning pretty well ever since we bought it.
So
So
if
they
the
have a good
AMC
life.
is maintained, so we can use it.
Yeah. Yeah. Therefore, if they're able to perform their functions well, do a real-time monitoring of
Mhm.
pH and CO2 temperature, then if they're able to maintain well, so why can't you use them for culture?
Yeah, true, sir.
सर एक CO2 incubator
कल्चर ज़्यादा आजकल लोग बेंच टॉप में करते हैं, बट
तक
हेरा
यूज
से
करते हैं, मैं
वर्क
कितने
क्वाइट
साल
वेल.
तक यूज कर सकते हैं?
ये संगीता बोलो, आपकी आवाज कट गई थी, प्लीज से.
ओके
संगीता बोलिए
Is
प्लीज.
talking to somebody else. Sangeeta is
अच्छा.
not
हाँ
talking to
मैम,
you. Yeah, she's talking to someone, I think. Yeah.
इट इज नेटवर्क इशू.
Okay.
सर मैं गुड इवनिंग सर, मैं एक सर क्वेश्चन मतलब
Sangeeta, your voice is not coming. So let me just reframe the question. So do you believe that which equipment is the most fragile equipment, which we should retire after a particular period of time?
It's an interesting question. We would like to know the opinion of embryologist.
मैम इट्स इंक्यूबेटर.
इंक्यूबेटर तो डॉक्टर सरप्रीत ने बोल दिया ना कि आप 15 साल से वो यूज कर रहे हैं, उसके बाद भी यूज कर
नेटवर्क
सकते
इशू आ गया था, मैंने सुना नहीं.
हैं. अच्छा, ओके. और क्या हो सकता है? what else? Like you have a stereo zoom, you have inverted microscope, you have manipulator. Or you have HEPA filters,
I think
inline
HEPA filter,
filters.
maybe HEPA.
Yes.
Inline filter has to be changed.
Yes मैम filter.
Yes, but that's not obviously equipment नहीं है. Sir कहेंगे equipment नहीं है. Yes, that's not equipment, but as an integral part of equipment. So next question.
So which instrument did you say?
No, I did not say any equipment, but what I personally feel is कि sometimes with a microscope,
Yeah, I was
yeah,
also.
they sometimes create lot of mess because of the
More than that, I
quality.
think some new version of the microscope comes, and that time maybe we need to update or something like
Yes,
that.
or anything like Dr. Sarapri said, like anything which is not working with all the calibration and all the care required we are giving, but it's not working properly, then it's time to better change it for the new one.
True.
So what is the equipment? What equipment do you recommend to have a backup of in ART lab? It could be
Incubator.
anything.
Incubator. Benchtop.
मैम यूपीएस.
हाँ, yes,
Every lab.
Sangeeta.
Every lab should have a backup incubator.
Yes, backup incubator and
That's the
UPS.
Backup ovum pickup, that suction apparatus also. we should have.
Yes. What else? Sir, throw some light or there.
मैम माइक्रो पिपेटर्स also we have full backup.
Very nice. Yes. In general, we always have, a little bit more extra micropipette, but yes, micropipette and denuding handle. We should always
Yes
keep
ma'am.
backup along with, as Dr. Shraddha said, that suction pump and the incubator, obviously.
I think for everything we should have a backup. Even that probe guide.
Yes.
Yes ma'am.
Probe guide is also like all the clinicians
Second.
always buy 2 to 3 biopsy guides. They always have the backup of it. So yes.
Yes, ma'am. Patient database and record
What is
keeping system.
most important is that definitely we should have a backup, but prior to that, when we have the pickup, we should check all the instruments that it is working. We should have a round and make sure, and we should have in the mind that what if any instrument goes wrong, what big backup we have. So that thing we should have.
Right. So when I was typing this question, I had this query in mind. Let's say we have backup of suction pump and we got all the oocytes, right? But let's say if the denuding handle or micropipette or anything which is non-replaceable, right? Denuding handle, let's say, if it is not working, then how you will denude your eggs, how you will perform ICSI,
No,
right?
I think my answer in this would be because it takes time, because we have to keep it in the incubator. So 3-4 hours is a big time in which we can have a second one, isn't it?
We can have the second one, but that is always, that is always in a different set of mind. So why not to keep a back of it? Okay.
Definitely. We learn from every webinar. This is what I learned it.
So next question is, what is the role of molecular technologies, laser assisted hatching, etc., in assessing embryo health and how they influence the selection process?
Laser hatching for PGD.
No, laser hatching as a laser hatching, if there's a zona thinning, thickness is there, then
As far as I know, the laser hatching is not recommended. Maybe I would like to update myself. It's not recommended as such, because if you have good embryos, 5A, it is equivalent to laser hatching. But I think the more important the role of laser hatching comes when you need to perform PGD for the patient, and you are thinking of some genetic disease or previous failures. I think there comes the role. I would like to know your opinion also.
no. So, ma'am, when see, or not all the embryos meant for day 5. So, if you have limited number of embryos on day 3, and you
Yeah.
have very thick zona,
Mhm.
that time you can just slice a bit of zona with the laser assisted, laser assisted hatching. Then not the hatching actually, it's a LAH. So you can just
LH.
cut down little bit of zona so that the implantation can be, achieved, or better chances of getting implanted. So other than
Yes, ma'am, and also useful in older women for benefit in certain older women also with thick
Pooja, thinning,
using laser hatching and also support during.
there is no evidence as such in favor of laser hatching or laser thinning also. But yes, in vitrified embryos from old patients, we tend to uh, hatch the zona, and if we have seen that it's an implantation failure cases repeated, then you might think that it's unable to hatch, and then you can try hatching. But yes, there is no evidence. There is no evidence for laser hatching or laser assisted thinning or anything of that sort.
what about other molecular technology like PGS, PGT? What is the
PGTA again, if you read Cochrane, तो किसी का भी रोल नहीं बताता वो तो PGTA has got no evidence as such other than ranking the embryos, and it just minimizes the or decreases the time to pregnancy. There is no other role. Otherwise, it doesn't correct an embryo. PGTM has a definitive role in thalassemia and single gene disorder monogenic diseases. You can discard the embryo, or you can select the embryo based on the PGTM results. PGTM, PGTSR, there's a definitive role. But PGTA has got no definitive role. Other than that you can rank the embryos.
One thing I would like to add from the clinician point of view, that PGTA and NICS, I think it is very upcoming and very useful in cases of recurrent pregnancy losses and recurrent implantation failures. Many a times, like patients of recurrent pregnancy losses, they're like, "Madam, pregnancy to ho hi rahi hai, fir IVF क्यों करना है?" So in that case, what we can offer them, like what we have seen that, and many studies also show that if we transfer good quality euploid embryos, then chances of getting them a healthy pregnancy is more. So there, I think there is certain role of this molecular technologies. Nowadays, non-invasive chromosomal screening is also available. So NICS, PGTA, we can get good quality euploid embryos, and then we can use them in those patients.
Yeah, provided other risk factors of recurrent implantation failure
Yes,
has
yes,
been excluded.
definitely. All other risk factors has been excluded. Obviously, after that, we can offer them this thing.
Yeah, true.
So yeah, obviously all the technologies, whether it is a molecular or they also give us a insight how to grade and what to transfer. Because whatever number of good quality embryos we are making with good quality of blast we are making, but if we don't know what is the, quality actually in terms of genetic analysis like PGA or PGTM, Dr. Sarapli Singh is saying. So yes, they definitely give us a very clear view that which should be transferred to get the better outcome. So I feel that way that these things kind of help. Obviously, in not all the cases. This is again a tailor-made approach. Who want such techniques? Who are the patient to whom we can offer these PGTA and PGM?
Yes. Also, if you're doing PGTA, we are more confident in doing single embryo transfers, which is the need of the hour. So I think if we get one euploid embryo, then single embryo transfer gives similar result as double embryo. So I think molecular technologies are very upcoming and they are the need of the hour.
So Dr. Pooja,
And you
if
should have
a
many
patient has
embryos.
got 2 embryos, will you go for PGTA? Or
Sorry, sir.
if the patient has got just 2 blastocysts, will you still go for PGTA or you will just transfer?
So basically, it depends upon the patient's other indications of PGTA. We don't offer PGTA to all the patients. But yes, if patient is like more than 38 years old, going with self gametes, or their previous history of any abnormalities or recurrent implantation failure, like recurrent IVF failure or recurrent pregnancy loss, then we definitely offer them PGTA or NICS.
No, but you offer them, but then at the end, if they have got just 2 embryos.
Yes, yes. In 2 embryos
Instead,
also we offer
in,
them, like in high risk cases.
and if there is just 1 embryo, then
Sir, I think in that case, proper counseling and transparency is
yeah,
important. Like,
that,
let the patient decide what they want.
Yeah,
exactly.
we should tell the pros and risks both.
Yes, yes, yes. Let them decide also.
Patient भी कहाँ decide करते हैं, कहते हैं आप decide करो हमारे लिए.
सर
Sir,
नॉन
decide
इन्वेजिव
कर देंगे, but उनको बता देंगे कि आपको तो ये सब
हाँ.
बताया था.
Yeah, you have to document. That is most important.
Yeah, yeah.
Yes.
सर
So
नॉन इन्वेजिव इम्प्लांटेशन जेनेटिक टेस्टिंग का कितना मतलब परसेंटेज है पॉजिटिवली?
Are you doing routinely this PGT?
No, we are
No,
not
no,
doing.
to Sarappreet sir, may I ask this question?
Dr. Sarapreet, are you doing routinely these PGTA cases? I think he's not. So, ma'am, generally, it's a very strict criteria now. We cannot offer PGTA to
We
everyone.
cannot offer to all. Yeah.
Yes. So it's very, very, strict or
What
stringent.
is your protocol? I want to know.
And there are
We-
PCP criteria, so we cannot offer to all basically. There
Yes.
has to be a certain proper indication. Like we cannot offer to a 30-year-old lady who has just, it's her first chance for like tubal blockage. And we cannot offer them PGTA. But
There
yes,
may be a strong indication
yes,
where we can go for like advanced maternal age or paternal age. Father is of higher side, so where the risk of aneuploidy, then we can transfer. Recurrent implantation failures के cases में we can go for such thing. Or if the known cases of some kind of deformities, then we can offer this PGT to them, but
yes.
not for all.
There has to be a specific reason.
Yeah.
Yeah. And it's very expensive also. See,
Yeah.
not everybody can afford just to have.
Actually, there should be an indication, like it says recurrent. I'm just from the clinician part. It says recurrent pregnancy failure. We do the genetic test of the product of conceptus, send it for the NGS. If there is any defect, then if she is going for IVF, then she needs a PGT. Or if she has recurrent implantation failure, those are the indications. but not routinely.
Yeah, I have a story. Like one of my patient, we got around six very good blast, and we transferred two at a time because she was around 36-year-old. But she conceived, and later on, we find out that there's some like she aborted, and we find out there's a genetic abnormality. So next time onwards, we just do the PGT of all remaining embryos, and we could not find any euploid embryo for her to transfer. So that was the sad part.
Ma'am,
Yeah, please, Sangeeta.
ma'am, PGT highly reliable or 100% accurate?
No, not
Not
at all.
reliable, but there's a category, clear category of euploidy, aneuploidy, and mosaicism. So obviously, mosaic,
Hmm.
in cases of mosaic, we can have 50-50 risk. But if it is showing us a strong evidence of aneuploidy, then why to unnecessary? And when we
Yes.
already knowing that she has suffered once because of this, why to offer that? In such cases, we always offer to go for a donor oocyte.
Yes. Thank you, ma'am.
Okay, moving towards the next question. So, in terms of embryo selection for transfer, how does the combination of lab environment, culture condition, and molecular profiling influences the decision making process? So, I think we have already discussed this
Yeah.
question. We are discussing it's a
It's the
part.
lab environment which helps in making a good embryo. But once the embryo is made, it is the, if we are not doing PGT, then this is how we choose it, the top grade. And that is what we do the embryo transfer.
Yeah, right. So because lab conditions sometimes generate lot of ROS, they could be and not so good quality embryo. We cannot predict that the culture condition we are providing it's that all healthy. So monitoring is important, and whatever, if it is a prolonged time we are not getting the implantation, but we are getting a lot of good looking embryos, then definitely we have to double check with the culture condition and lab environment, that whether having, despite having good quality look like embryos,
Yeah.
and why they are not giving us the positive outcome. So that is how, or obviously that grading makes a lot of impact. How you grade your embryo among the lot is also very, very important.
Yeah.
Next. So now we have time lapse, we have lot of uh, softwares which generate lot of data. So with so much of data available, do you ensure that decision making process in both accurate and ethical? And how do you handle situation where there are uncertainties or ambiguous result? So how you will deal with such conditions?
I think, as I already mentioned, proper counseling and transparency with the patient is the key factor in all these things, and proper documentation of all the conversations with the patient. In that case, we can very easily deal with these cases.
Yeah. So keeping the patient informed at every stage is very important. From the day of stimulation, the number of eggs she had at the time of ovum pickup, the number of M2 she had, how was the ICSI, the sperm quality. If we keep patient informed at all the stage, it would be easier for us to counsel about the embryo, the type, whatever embryos we have got.
Ma'am, I think we should make a strict SOPs to ensure consistency during handling and culture condition and selection media also.
Right. Anything from Dr. Saraprit or Dr. Dayanvi?
I think most important is, like Dr. Shraddha also said, most important is counseling. And documentation also, what you're explaining to the patient, because then video consenting is also quite a good option nowadays, and so which helps in decision making, as well as it makes an impact, because we also face situations where patients have come back to fight with us and argue with us, and then we always had the video recordings of so they can't turn back on what they said. And also merely signing is not important, but the fact that you have explained things is also very important, and that is quite ethical also to do that. And how do you handle situations that are uncertainty?
Right.
So I think counseling and documentation is most important for uncertain and ambiguous situations.
So it is very important. Just signing in the consent is not important.
Yeah, documenting and video consenting is very important nowadays.
So do you feel that all the ART clinic should have a psychologist like who can guide the patient for all such things? Do you feel the importance of it?
See,
Or
I've seen
IVF counselor, I would say rather.
clinics where they have trained IVF counselors and all, but when it really comes to the decision making, they want to meet the doctors only, and the final word comes through the doctor only. So counseling is good for basic counseling and all. You should have a counselor, but decision making, I think patients do look up to the doctor only.
Right. But like just to make a point here, two things are important. I feel since the beginning that IVF counselor is not just like Dr. Shraddha said, not just to make a sign on the consent paper. Patient should be properly informed what is written and what is written on that consent paper. They should completely understand. It should be bilingual so that there should be no language barriers. And in with each every step, let's say we got some monitoring. During the monitoring we got, let's say, left side or right side tentin follicle we have seen, but during the OPU we might end up having lesser number of what we predicted, and which is very very obvious. So that time also, after the OPU, we have to inform the patient that yes, we got this much number of oocyte, and now further we got like this much of M2s, or what quality. Sometimes we landed in such a situation where we are thinking that we'll get good number of oocyte and good quality, but we end up in a very miserable situation where after having 10 oocyte, we got only 2 3 mature or good quality fertilizable oocyte. In those all such condition, we should always counsel the patient, and we should have in the writing that yes, we have well informed you about after every process. Like if the embryo is if the sperm quality is not good, then also we can ask them or tell them that yes, you have very poor sperm quality, what you want to go with. Some people, some patient, they ask for, some, they can go for the donor if there's a very bad situation. Otherwise, they prefer to go for IVF or ICSI. What procedure you are doing? So there's a role of counselor is very, very important, and informed consent is very, very important. This is one point which is from the ethical perspective, and we have to know how to use the data since the beginning of clinical diagnosis, how the patient profile was, and now how the go like oocyte which we are going to inject. So oocyte quality predict a lot about the fertilization failure or good quality embryo. So every data is important. We have to compile before going for the final counseling of what is the failure, chances of failure after implantation, or chances of success. So that is how we can just take care of all that uncertainties uh, if anything comes after the procedure of failure. So should we move to the next question?
Yeah, Pooja, I think you were right in saying that you should be transparent to the patient, but transparency up to a limit is okay, because हमें खुद ही नहीं पता होता, eggs are looking good but then they might not fertilize, so always थोड़ा buffer लेके ही चलना चाहिए. Always explain that you should always keep a 30-40% attrition rate in mind while counseling to the patient. We
Right,
always feel that.
right.
कम का ज़्यादा हो जाए ना, they feel good. ज़्यादा का कम हो जाए, then they come to us.
Yes, exactly. That is why I raised the
30-40% margin, I mean attrition rate हर चीज़ में, 10
yes,
egg, 7 mature. 7 mature, 5-6 fertilize. 5-6 fertilize, 2-3 good quality embryos. That kind of counseling should always be done, I feel. And if you have more, you can freeze and you can tell them. But if you decrease or go on your this thing, then they don't understand then.
right, sir, right. So that is how I learned this process, because in Delhi, patients are so much knowledgeable. They are well-read patients.
Yeah,
So you cannot simply tell them, like sir said, they should be always keep a buffer in mind. Exact number we cannot simply say, because if it is something or idhar udhar hua, then patient will start,
yeah.
saying all
I
that.
do have some of my patients, not all. They are so like maybe through the YouTube, they know what is M2 and this, that, everything, the stage, the grade they will ask.
Yeah, so that in few cases we were like bombarded with the patient question. So we make a SOP. We made that SOP that in any coming situation, we are going to tell the patient that, see, we have got this much of oocyte, but the number of M2s are little lesser as expected. So you may not get that good quality embryo or lesser number of embryo. So keeping the system safe, you have to be little bit. Obviously you have to just make sure that exact number आप ना उनके साथ share करें. So moving forward, question number 8, and this is second last question. So what are some of the future directions for lab environment and culture condition that you see in terms of optimizing embryo health and improving IVF outcome? For this question, I would request sorry, everyone to make one point. So start with Dr. Shraddha.
It should be proper monitoring. That is in the future, I think more monitors, more sensors, a proper AMC. But I'd like to know more from the embryologist.
Yes, Dr. Pooja, what is your direction to optimize it? Dr. Sangeeta? Am I audible or they all left? Dr. Indra?
No, you are audible.
Yes, ma'am. Yes, ma'am. If I want to say, ma'am, if we in future combining AI technology with time lapse imaging to also predict the most viable embryo and more accurately transfer artificial intelligence. Ma'am, it is future, matlab not a
Future.
using.
See, we are talking about future and you brought it very nicely, AI. So कहाँ आप AI fit करना चाहते हो?
मैम नॉन इन्वेजिव टेस्टिंग के साथ भी हम लोग कर सकते हैं, जिसमें जैसे निक्स वगैरह हम लोग करते हैं इसमें.
सॉरी, मैं समझ नहीं, आप फिर से बोलोगे?
मैम नॉन इन्वेजिव टेस्टिंग and in metabolomic profiling also.
Okay. So my friend Daya was about to say something. Daya, you are the director. So give us direction, future directions to optimize the lab. Dr. Dayanidhi?
Yes, am I audible now?
Yes, you are.
So definitely, the AI and machine learning integration is very, very important for future. In addition to that, advanced culture media, we may go for customized culture formulation based on genetic and metabolic profiling. That maybe when we get into the NMR, and we know that some of the embryos in the like pre-compaction embryos prefer pyruvate based and glucose based. We may in the future we can go through that. Definitely non-invasive embryo assessment, NICS, we are performing, but it's not up to the mark. So definitely it can be, added in the future. The microfluidics, again, on lab on a chip technology that is, upcoming. Robotic ICSI, we all know that is upcoming in our, system. Maybe it would be like if you can get, epigenetic and genetic screening advances. See, right now we are not going through any of the epigenetic changes. We don't have any any technology where we can actually check the epigenetic effect of whatever handling we are doing. And then I don't know, maybe personalized IVF approach for some of the patients where we need that. Anyway, we are doing, but yeah, these are all the things that that can be
सर
incorporated in future.
सर जैसे अभी क्रिस्पर तो यूज नहीं होता बट क्रिस्पर टेक्नोलॉजी हैज द पोटेंशियल टू करेक्ट डिजीज कॉजिंग म्यूटेशन एट द एम्ब्रियो स्टेज इज इट राइट और
There are so many things.
Far away from the
What is CRISPR? I would like to learn.
cluster regulator regularly interspace short. Actually, it is detecting the DNA strand mutation.
See, one more thing, like, we all know that in the implantation process, there are 150 factors which are very, very important for implantation. And with the current, the technology, we know only about, 5 to 7, whether it could be the pinopods, whether it could be the material thickness, maybe the blood flow and other thing. So definitely we need some technology maybe in the future where we can assess these implantation factors in the endometrium, by which we'll be able to get 100% implantation potential. So if that can be done, it would be a great approach in the future.
Then we will have 100% IVF success.
Most probably, yeah, we are expecting
100%. I doubt about it, but I think yes, future is lies in AI and all those things. But for now, I think we can focus on three things, and after that, I will just wind up this panel. That SOPs are very important. Skills of the performer are very, very important, and obviously the ethical practices for today's era is very, very important. So with these three things,
but Pooja, this is not about the future. This is the most important thing that we have to follow every time.
Yes,
SOP,
I'm saying
and whatever
future,
you said.
yes. Future isn't AI, obviously, but yes, for now we can sum up with this, not with the future. Future, as I don't know, so many things coming up.
Future is in AI, it is in robotics. But I think it's a long way to go for AI to... AI, I feel, is overhyped, especially in IVF. Automation might, come, but AI को कितना time लगेगा अभी कहना बहुत मुश्किल है, because presently whatever the AI is, it is not improving upon what we are doing with our whatever little brain we have. So AI भी वैसे ही कुछ काम कर रहा है, and it is not improving any results, neither time lapse, not any of the embryo assessment softwares. Nothing has worked well till now. So I think it's a long way to go, and then things have to be designed as per our Indian population. ऐसा नहीं है कि Western markets के हिसाब से सब कुछ नहीं चलेगा. We have to customize and Indianize the things also. I think Pooja rightly said that we have to first focus on the basics, like the proper training, follow them, don't deviate from them. It is all about training and following and maintaining airtight control in the lab, having good witnessing systems, not witnessing systems, alarm systems and other control systems. Witnessing, yes, if you can afford, getting the proper softwares, linking everything together, and moving slowly towards, automation and AI will help. Not looking forward and completely changing might not help, but slowly stepping towards a better lab environment and a better technology and slowly adopting it and adapting to it both. And that is I think the future which has to in store for us. But again, if you are only viewing AI, तो वो सिर्फ सुनने में अच्छा लगता है. It may or may not work as of now. People talk about AI, but when you ask them the difference between AI and automation, they are not even able to explain. So ये भी एक दिक्कत है कि people don't understand, but they flaunt things. So try to
I
understand the
completely
technology.
agree with you, sir. Yeah, I
Completely,
completely agree with you, sir.
plus understand the technology. अब हर कोई सोचता है कि मैं embryo biopsy कर दूंगा, but many times euploid embryos also don't implant. So
Yes.
ultimately, you have to understand the technology and
The
then
various
market it.
factors for
I
implantation.
Yeah,
have
The
a
pacing
question.
factor
yeah,
is equally important.
I have a
absolutely,
question.
absolutely. I mean, I'm not. Don't take me wrong when I say that, but understand the technology and then recommend it and advocate it to the patients, because ultimately it's a very hard-earned money which goes into adopt buying at any test which you are recommending. So many times I've seen that clinicians are writing so many immunological tests, but when the result comes, they don't even know how to interpret those immunological results, and then there is no next thing in their mind. So understanding is very important. I mean, understanding the utility and the inference you are getting out of it is again very, very important.
Sir, I
So,
have a question.
हाँ जी मैम बताइए please.
Yeah, if PGT has been done and embryo shows that there is aneuploidy, they are not euploid embryos. So, what you actually recommend for these embryos? All embryos should be discarded, or considering the prevalence of mosaicism? Because there was an article, I'm forgetting all the details, but it said that they also give good pregnancies are there. So should they be
Mosaic embryo तो pregnancy दे ही देते हैं मतलब, and then mosaic also is nowadays ASHRAE is classifying less than 50% and more than 50%.
Yeah.
Less than 50% mosaicism है it has been shown to autocorrect. But again, again, then the other classification is 20%, less than 20%, and then 20 to 60%, and more than 60%. Oh, sorry, 20 to 80%, which is a gray area. उसमें आपकी choice हो जाती है, और more than 80% is as bad as aneuploid. Less than 20% is as good as euploid. तो बीच का जो window है, उसमें थोड़ी ambiguity है. But again, if there is no choice, actually, if there is no euploid embryo, talk to the patient.
then,
अगर 40%, 50% mosaicism.
Yeah. Then after
out of these three embryos,
everything,
two are aneuploid, one is
should
mosaic.
be done.
तो mosaic करने में कोई बुराई नहीं है मेरे ख्याल से, है ना?
हाँ.
It is worth taking that chance because the effort has been done. पूरा आपने कर लिया, और mosaic 30-40% mosaic पे there have been many reports which say that they have given pregnancies.
Yes.
तो ऐसा नहीं है कि pregnancy नहीं आती है, but yes, there is no assurance. But then there is no assurance with euploid embryo also. वो तो फिर embryo transfer scale, endometrial embryo interaction, receptivity, there are a lot of things which come into play.
Sir, can I answer something? Can I speak something?
हाँ जी ma'am, please.
So when we are doing there are chances that there could be that the embryos are mosaic, and when we are taking the cell, it could be a mosaic, which means some of the cells may be aneuploidic, which we have taken out, and that shows it is aneuploidy. But exactly more of the cells would be normal, and there is a high chance that it could implant.
That is the
See,
case.
mosaicism also is dependent on कि आपने कहाँ से biopsy ली है. आपने तो 6 सेल उठाए. आपने मतलब
mosaic
is a mixture.
भी हो सकते हैं सर, वो सारे
No,
mosaic
it is a mixture of, yeah. It is a mixture of cells, There are two things. It's a mixture of cells. So if there are 10 cells, उसमें से मान लीजिए कि 3 सेल mosaic हैं. आपने वही तीनों उठा लिए, है ना? आपने एक ही उठाया, आपने दो ही उठाए. So your numerator always changes, and denominator also changes because it is divided by the जो denominator होता है वो भी change होता है because when you hit with DNA leak which takes place, तो जो DNA leak है वो भी कुछ DNA contribute करता है. So it's a very subjective thing, and there have been lot things which have been written about this. और दूसरी बात ये है, I would like to bring, I was reading an article, उसमें उन्होंने ये लिखा था कि जो ट्रोफिक्रम सेल्स हैं, आप उनकी बायोप्सी ले रहे हो, एंड एज सुन एज द इम्प्लांट दे टर्न इनटू, मोस्ट ऑफ देम विल टर्न इनटू यूप्लॉइड, ऐसे, बिकॉज उन्होंने कुछ एनिमल स्टडीज में ऐसा देखा है. सेकेंडली, दे हैव कंपेयर्ड इट टू अ कैंसर सेल. कैंसर सेल जो होते हैं वो हमेशा मोज़ेक होते हैं या एन्यूप्लॉइड होते हैं. वाई? बिकॉज दे आर सपोज टू इन्वेड. ऐसे ही ट्रोफिक्रम इज आल्सो सपोज टू इन्वेड. व्हेन इट इन्वेड्स, उसके बाद वो मोज़ेकिज्म कम हो जाता है, मोज़ेसिज्म. सिमिलरली जो कैंसर सेल होते हैं वो भी मोज़ेक होते हैं, बिकॉज उसका नेचर भी इन्वेड है. बट कैंसर सेल्स डू नॉट चेंज देयर कैरेक्टर, बट trophiodome cells do change their character, and shown by the number of babies who have been born normal out of mosaic embryos. तो ये कट ऑफ तो आपको खुद ही ड्रॉ करनी है कि 50 पे नहीं करूंगी, या 60 पे नहीं करेंगे, या 40 पे नहीं करेंगे.
Thank you, sir. Thank you, sir, for your very valuable input.
And report also gives very good graph and everything with very, deep percentages of everything. Then you can also decide. So I would like to request everyone to please switch on their cameras for the last click so that I can click this webinar properly. Thank you so much. Okay, Kalpana ma'am, Dr. Indra, Daya, Dr. Dayanidhi, Sangeeta, Pooja ma'am. Thank you so much. So I'm going to take a screenshot, the smile.
फिर से पूजा,
अच्छा,
just
फिर- okay, yes,
take
yes.
it again ना, take it again.
Big smile.
Thank you so much for the wonderful session and interactive one. So I think it's a good session to end up, and
Bye-bye.
time also. Yes, please, sir. 4 minutes left for you.
I'm asking, कैमरा बंद कर सकते हैं अब?
Why not?
Thank you very much, everyone. Thank you.
Nicely, yeah, but
Very nice.
very good input
Word received by Dr. Pooja.
Albert.
Congratulations.
Thank
Dr. Shraddha,
Thank you,
Dr.
Dr.
Pooja.
Pooja.
Thank you, sir. Thank you, Kalpana.
Thank you, sir. Thank you,
Thank
ma'am.
you,
Thank you, ma'am. Thank
Dayanidhi,
you,
sir.
Dr. Dayanidhi, sir.
Everyone
Dr.
has spared their valuable time. Somebody is on phone, somebody is on car. But thank you so much, Kalpana ma'am, and everybody else. Thank you so much. Bye-bye. Take care and happy Holi to all of you.
You did so
Thank
nice.
you. Bye. Good night.
Thank you, Pooja. Thank you. Good night.
Bye-bye. Bye-bye.
Thank you, Saraprit sir. Thank you very much for the opportunity. Thank you.
Thank you, ma'am.
Thank you, Dr.